All right, let's get started here. So I'm Josh Radke. I'm a medical toxicologist here at the University of Iowa, and I'm going to talk today about rodenticides. All right, I've got nothing to disclose. So rodents, and rodenticides. So rodenticides covers a pretty wide variety of chemicals and mechanisms, and the chemicals themselves aren't necessarily related in any way, other than that they all target rodents, ideally. So we generally think of just kind of mice and rats, but certainly some of these target squirrels, gophers, some of them target birds as well, and then certainly if you use doses large enough, you may be able to target rodents of unusual size as well. So the outline, kind of what we're going to talk about. So again, broad range of topics. There's a lot of different chemical compounds, and it covers quite a big chunk of Gold Franks. So it's a rodenticide chapter plus about 10 other chapters. So it's a pretty good chunk. And it's pretty good board fodder, even though, many of them aren't used in the United States. Most of them we probably will never see in our career, but certainly why would that matter for toxicology boards? But there is a lot of good pathophysiology, and it's pretty easily testable because many of them also impair kind of basic biochemical pathways, things like glycolysis, citric acid, oxidate phosphorylation. So it's pretty good board fodder. I will say just as far as my source, so a lot of this comes from Gold Franks, so there's not a lot of human literature on a lot of these, and kind of primary literature. I try to look for some of them for each of these drugs, and most of the literature I did find was already referenced in Gold Franks. So that's a primary source for a lot of these. And we're going to hit the high points. So as you can see, there's a lot of chemicals there. So don't have to spend all day on this. And some of these, like arsenic, cyanide, could be whole lectures in and of themselves. So we'll kind of hit the high points, spend 1 or 2 slides on each of these. So first, a little bit about rodenticide regulation. So everyone's favorite, some alphabet soup here, just a bunch of kind of random acronyms. So rodenticides are regulated by FIFRA, which was started in 1947, and that's the U.S. Federal Insecticide, Fungicide, Rodenticide Act, which covers all pesticides. And then EPA was given the authority to administer and enforce FIFRA in 1970. And it does this through several different acts, some more acronyms here. So there's RCRA, the Resource Conservation and Recovery Act, CERCLA, Comprehensive Environmental Response Compensation Liability Act, also known as the Superfund Act, TSCA, Toxic Substance Control Act, and then the Clean Water Act and the Safe Drinking Act are all the kind of acts that regulate these pesticides. So as far as classifications, there's a couple different ways that you can classify pesticides and specifically rodenticides. So you can classify them as inorganic versus organic based on animal selectivity, based on the nature of onset of symptoms, or most resources, including Gold Franks, usually use the LD50. So again, that's just the dose that's required to kill 50% of subjects, which is usually rats in most of these studies. And you can see the different categories for the EPA classification there. So there's 1 through 4 based on the LD50 as shown in the table there. The LD50 does have an advantage in that it's pretty similar among different mammals, so it's a little easier to extrapolate that data to humans. So most of the rodenticides we're going to talk about are the class or category 1, which is danger, or with the LD50 of less than 50 mg per kilogram, with the exceptions noted here. So there's 2 in the moderately toxic, ANTU and cholecalciferol, and then there's 3 in the low toxicity or caution range. All right, so that's the classification. So now we'll get on to the drugs. So I just put them in alphabetical order. That seemed the most logical and easy, so we'll just kind of go through the alphabet here. So start with alpha chlorulose. So this is primarily used in France, Europe, also used as avicide, so in order to kill birds as well. And it's actually used clinically for a veterinary anesthetic because it causes CNS depression. So exposure to humans also cause anesthesia, essentially, mainly get CNS depression. There's also some abnormal muscle activity, so myoclonic jerking and seizures have been reported as well. Most human exposures are non-fatal and not really that significant. No antidote as for a lot of these rodenticides, so treatment is just going to be supportive. Next up is ANTU, or alpha-naphthylurea, and this predominantly injures the lungs, so you get injury to the capillary bed, causing increased permeability and fluid leakage into the alveoli, so you get acute lung injury and the bronchorrhea along with it. So there's pretty limited human data, which is kind of the case with most of these rodenticides. So a lot of toxicity of this and the other rodenticides we're going to talk about is derived from veterinary literature, because dogs pretty commonly get into rodenticides as well. So there's one case series of ANTU plus chlorelose where they found 14 patients who took that combination, and 11 of the 14 required intubation for increased secretion. So it seems to be a pretty common side effect of exposure to this rodenticide. Treatment, predominantly supportive. There's been some experimental treatment options. They looked at morphine and fructose 1,6-diphosphate that may prevent acute lung injury, at least in experimental models, and the thought is that they inhibit the inflammatory cascade. Other kind of case reports have used dexmedetomidine, ketamine, midazolam. A lot of these are all rat studies again. Another treatment option might be activated charcoal if you get them early enough. All right, so next on to arsenic, arsenic trioxide specifically. So this is an inorganic arsenic form, which is the form used in rodenticide. And interestingly enough, this is actually used in humans for the treatment of acute promyelocytic leukemia. But there are other forms of arsenic as well. There are the organic forms of arsenic. So arsenobutane is probably one of the more common ones, and that's what's found in seafood and the cause of most elevated arsenic in countries like the United States, where we don't have a lot of other arsenic exposures. And arsenobutane is very low toxicity. There's some other organic arsenics that have therapeutic use as well. So melarsoprol is used in treatment of African trypanosomiasis, and then thiacetarsomide is used in heartworm therapy for dogs, actually. Probably the I guess most famous example of arsenic toxicity is hydroarsenicism, or all the water wells that were contaminated in Bangladesh. Is most commonly the country we think of when we think of arsenic, but there's a lot of other countries that have similar situations. And ironically, the wells in Bangladesh were drilled to provide safer drinking water from more bacterial contaminants, but then they got into some water that was contaminated with arsenic. So as you can see, the map on the right shows kind of the arsenic levels in the groundwater within Bangladesh. So the EPA in 2001 decreased the contaminant level to 10 parts per billion, or 10 micrograms per liter. So looking at that map, that's pretty much anything that's kind of green, orange, or red on the map pretty much have levels of arsenic that are too high as designated by the EPA. So that's a large majority of the country there. So in Bangladesh, we saw more kind of the chronic toxicity, classically the chronic skin changes, hyperpigmentation, you can see in the picture there in the middle. Other things you can see: hypertension, diabetes, peripheral vascular disease, and then some malignancies are associated with it as well, including lung, bladder, and liver. When we think of more kind of acute toxicity, so if somebody gets into rodenticide with arsenic, we think of kind of different toxicity associated with that usually. And there's two different forms of arsenic, so the 3+, the trivalent, and then pentavalent, or 5+. And the overall theme of kind of this whole slide, it's kind of busy, is that arsenic impairs ATP production, but it does it through a couple different mechanisms. So starting with the trivalent arsenic 3+, So it essentially impairs any enzymes that require lipoamide for cofactor. You can see the diagram there, kind of the bottom left. Essentially, arsenic prevents the recycling of lipoamide. So the main enzymes that use that are pyruvate dehydrogenase and then alpha-ketoglutarate dehydrogenase. And so pyruvate dehydrogenase, by inhibiting that, you can decrease acetyl-CoA, so you decrease ATP production as well as decrease gluconeogenesis. And then alpha-ketoglutarate dehydrogenase is the enzyme that produces succinyl-CoA, so you decrease porphyrin production and decrease amino acid production. Then you can also get some impaired fatty acid oxidation as well. Moving on to the pentavalent. So this resembles phosphate, so essentially a substitute for inorganic phosphate, and again, kind of impairs ATP production. So you can see the steps in glycolysis down below. It essentially bypasses the steps that produce ATP, so you decrease ATP production again. And then it also is an uncoupler of oxidative phosphorylation, which we'll talk about in a little bit as well with some other exposures. So clinical things, clinical symptoms, signs and symptoms. Classically, it's a garlic odor, which is seen in a couple of these rodenticides that we'll talk about. Another classic thing is the rice water diarrhea, but there's a lot of other things that you can kind of read there that are associated with it. Torsades, and some CNS changes as well. Onset's usually pretty quick, so as soon as 10 minutes to several hours before you can see some symptoms. Death can also be pretty early, as early as 1 hour up to 24 hours. And you can see pretty much any organ system involved. So you can get acute lung injury, hepatitis, acute renal failure, rhabdo, hemolysis. So management, like all things, kind of general supportive care, IV fluids, packed red blood cells if there's a significant GI bleed, standard recommendations and management for QTC prolongation, activated charcoal whole body irrigation. Like most things, there's no great studies, but it's worth a shot if you think they're going to be sick. And then there are some chelation options for arsenic. So first is BAL, and that's usually reserved for kind of critically ill patients. And then Succimer is more for your subacute and chronic exposures. The BAL does have some limitations, as it may shift arsenic to the brain, similar to the limitations seen with monotherapy for lead chelation as well. All right, moving on to barium. So barium carbonate is the rodenticide, but barium itself has other uses. Insecticide as well as rodenticide. Depilatory, we're probably most familiar with it as a contrast material as barium sulfate. It's got some other uses as well. Toxicity is most common after rodenticide. Most of those other forms are not really that toxic, so that's, again, the barium carbonate. And it doesn't take much, even as little as 1 gram can cause pretty significant toxicity. And how it causes toxicity essentially creates hypokalemia through kind of 2 different mechanisms. So one, it inhibits your potassium rectifier pump, which is a pump near and dear to our hearts. So it is involved in phase 3 of the cardiac action potential, but it's elsewhere in the body too. So essentially the cell can't pump potassium out of the cell. And then it also increases cell permeability to sodium. So going down to the picture down below, so sodium gets into the cell, and that kind of activates the sodium-potassium ATPase to pump that sodium back out. And when that pump gets activated, it pumps the potassium into the cell. So kind of 2 different mechanisms that cause hypokalemia. So toxicity is really just due to that hypokalemia. You get some dysrhythmias from that, but then the big thing you see kind of clinically earlier on is essentially just muscle weakness, and the concern with that is certainly respiratory failure. And part of that weakness may be due to a direct effect of barium. It's kind of unclear, and they think that might be the case because the degree of weakness seems to correlate better with the barium concentration than the potassium concentration. So it's kind of unknown, but definitely a couple ways to get weakness there. Other things you can see, so you get hypertension due to increased vascular resistance, and that can lead to decreased blood flow, anaerobic metabolism, and lactic acidosis as well. So management, Primarily, it's just correcting the hypokalemia and other kind of general supportive care. If you get them early enough, you can do NG or OG lavage. And then another option you can do is to essentially put some type of sulfate into their GI tract, so whether it's sodium thiosulfate or magnesium sulfate is another option as well. So if you give that orally, it essentially creates barium sulfate, which then precipitates out, and barium sulfate is insoluble and unabsorbable, so it just passes through the GI tract. It's just important not to use IV magnesium sulfate or any other sulfate, because that's going to just precipitate out in the blood, which is going to go to the kidneys and cause acute kidney injury. So it might require quite a bit of potassium. There's reports of up to 400 milliequivalents in 24 hours. And another thing you have to be aware of is that there can be rebound hyperkalemia, because again, it's not a total body deficit of potassium, it's just a shift intracellularly. So as soon as the toxicity is resolving that, potassium is going to start coming extracellularly as well. And another option is hemodialysis and CRT. Both can remove barium and also correct your hypokalemia if it's severe. All right. Next up is bromoethylene. So this is one of those that's in the category of the low toxicity or caution, with a LD50 in the 500 to 5,000 milligram per kilogram range. So this one's kind of interesting. So it's been available since 1986, but there wasn't any case of toxicity until about 1996, despite hundreds of cases per year with minimal toxicity. And then there were 2 deaths reported, both in 2005, but pretty much all other cases have had kind of none to maybe moderate toxicity associated with it. So the vast majority of cases do well, but every once in a while you can get somebody who gets pretty sick from this. So how it works is it uncouples oxidative phosphorylation. So our good friend there on the diagram on the right. So essentially by uncoupling it, the hydrogen ions travel down the concentration gradient, but it's not coupled to ATP production. So you get less ATP production. So what that leads to is predominantly kind of CNS symptoms, so altered mental status, ataxia, seizures, and things of that nature. And then on autopsy, you can see diffuse vacuolization in the white matter within the CNS as well. Treatment, predominantly supportive. Possibly lipid emulsion is pretty lipophilic, and actually the veterinary literature seems to support bromoethylene. I'm not sure it's ever been used to treat a bromoethylene case in a human, though. All right, so cholecalciferol is next. So this is just vitamin D3. So this is the same vitamin D that we either get in our diet or that's produced in our skin after exposure to UV light. So once you get the D3, it undergoes activation of the liver and the kidney, and then that results in increased calcium absorption as well as mobilizing calcium stores. And that's really where we get the toxicity, is the mobilization of the calcium stores. Pretty limited human data. There's been no reports of death or serious toxicity in humans. So a lot of this is either vet literature case reports, or a lot of it's just kind of based on management of vitamin D exposures and overdoses. But the big thing you worry about with this is essentially hypercalcemia. So classically, you get stones, bones, groans, psychiatric overtones, that's kidney stones, as well as some acute kidney injury. You get bone pain from the resorption. You get some abdominal pain, nausea, vomiting, and then you can have mental status changes as well. As far as lab tests, the biggest thing is going to be looking at calcium. One thing is that calcium might not be elevated initially because the vitamin D3 does require some activation, so it's not going to be an immediate increase in the calcium levels. You can probably look at vitamin D levels. They might not come back in a clinically relevant time frame, but it's something you probably want to check as well. Treatment, pretty much just managing the hypercalcemia, so IV fluids are kind of the go-to, and then depending on the level of calcium, you can do bisphosphonates, calcitonin, and maybe some Lasix as well, pretty much other therapies that are used for hypercalcemia. All right, next is cyanide. Not really something that's used in rat poison in the United States anymore. And this works by inhibiting cytochrome oxidase, which is a component of cytochrome A3, which is complex 4 in the electron transport chain. So you essentially inhibit that, and you get decrease in ATP production. There are some other enzymes that inhibits there as well, but the biggest thing we worry about is inhibiting the electron transport chain. So essentially, the patient's unable to use oxygen to produce ATP, so they switch from aerobic to anaerobic metabolism, and you get a pretty large lactic acid and an anion metabolic acidosis. Other things you can see is the narrow AVO2 difference, so essentially an elevated venous oxygen level, and that's just because the tissue and the mitochondria aren't extracting the oxygen because they're not using it. So the arterial and venous oxygen levels will be pretty similar if you check an ABG and a VBG at the same time. Treatment options for cyanide, there's two. So there's the cyanide antidote kit and then hydroxycobalamin. So the cyanide antidote kit has kind of three components. You have the amyl and sodium nitrites, and those essentially create a methemoglobinemia, and usually shoot for a methemoglobinemia of about 15%. And then once you give them those, then you give the patient the thiosulfate, which donates the sulfur, and then the cyanide gets converted to thiocyanate via Rodentase, and then gets eliminated from there. The other antidote for cyanide is hydroxycobalamin. You can see it's that big structure there on the right with cobalt in the middle. Essentially in the presence of cyanide will bind that cobalt, and that creates cyanocobalamin, which is just vitamin B12. All right, next up is elemental phosphorus, another one of those that is not used anymore as a rodenticide in the United States. Phosphorus is used for matches, fireworks, and munitions. The munitions are illustrated down in the lower left there, that picture. So there are two different forms. There are different allotropes, which means essentially the same atom, but they're just bonded together differently, and that's what creates the different properties. So white phosphorus is pretty much what we're talking about today. That's one of the toxic form. So it's spontaneous combustion air. It's insoluble in water and lipophilic, so you see that picture on the top right. The white phosphorus is in the jar of some liquid, maybe water. And then the red has pretty limited human toxicity. It is used in some recipes for methamphetamine production, which is where you can get some of the toxicity because it can be unintentionally converted to white phosphorus, which is highly flammable. But you can also generate phosphine as well, which if there's any Breaking Bad fans out there, that's what Walter White did to kind of take down these two guys. He essentially tried to create phosphine. So pathophysiology, the big thing we worry about here is dermal exposure. Now, in trying to find some pictures of this, Google image is a little bit too gruesome. So a lot of the pictures online are kind of from combat with some civilian casualties. So like I said, they're pretty gruesome. If you're that interested, you can certainly Google it. And we all have pretty strong stomachs, I'm sure, but they're still pretty gruesome pictures. So there's three different kind of mechanisms that cause damage for the dermal exposure. So you get caustic injury from phosphorus pentoxide as well as phosphoric acid. But that phosphoric acid also causes an exothermic reaction, which is probably the most damaging component of this exposure, and then you get some dehydration reactions for some of the organic molecules. You can also get pretty good systemic absorption dermally as well, which can lead to systemic toxicity. So even kind of 12 to 15% total body surface area is lethal in half of the cases, so you get some pretty significant absorption there. So if we're talking about kind of ingestion, you get some other effects. So it's typically described as 3 stages. So you get the GI stage, the quiescent stage, and then the hepatic injury phase. And those are all pretty similar to iron, so it can look pretty similar to that in overdose. But there is significant overlap and sometimes absence of that second quiescent stage as well. So similar to iron, it can affect pretty much every organ. You can kind of read through all the organ effects there. There's another one with the kind of garlic odor as well. Let's see. One thing that's interesting is this the luminescence. So the kind of green light down here at the bottom is phosphorus. So it's been used in the past for a lot of scientifically unfounded remedies. Since it glows, people would think that it must be doing something if it's glowing. That luminescence also limits its use for poisoning, because with the luminescence and smoking, there's probably some pretty good evidence of what was used to poison the patient with. The pictures on the far right are an example of phossy jaw, which isn't really an acute toxicity. That's a chronic effect. And that was seen in matchmakers in the early 20th century. They'd get osteonecrosis of the mandible, seen in the B picture there. And that's when they were using the white phosphorus for matches. They switched to red phosphorus, which does not have that same effect. Management, the biggest thing is kind of decontamination. So it's going to take large amounts of cool water. If it's just on extremity, you can submerge that extremity in water, and that's going to prevent that spontaneous combustion of the phosphorus, essentially. And then you want to get it out of any wounds as well, because if it's in the wound, there's probably ongoing injury as well from the caustic effect. So they used to use a lot of copper sulfate solution. The copper reacts with phosphorus. It produces copper phosphide, which is dark material that coats the phosphorus, which has two effects. One, it kind of neutralizes it, but also then you can see it to decontaminate the wound. But they used to use pretty concentrated forms of copper solution, so there was then reports of copper toxicity and hemolysis from the copper solution. So what a lot of sources recommend now is using a dilute solution and maybe just doing it a one-time application, again, to identify any remaining fragments and then to stop the ongoing damage. Other things you can do to visualize it is just turn off the lights, because it's going to luminesce, or you can use a wood lamp as well. There's no specific antidote for it. It's kind of general supportive care. Case reports have looked at use of NAC, superoxide dismutase, methionine, again, just kind of as a generalized reducing agent, but it's primarily supportive care. All right, so the next two rodenticides we're going to talk about are selective for rats only and are in the low toxicity category, so the caution with the LD50 in the 500 to 5,000 mg per kilogram range. So the first is norbromide, and this affects rats only with no known human toxicity. So it constricts smooth muscle via a norbromide receptor that causes essentially contraction of the blood vessels, and so they just get hypertensive emergencies essentially and all the complications that go with hypertension. In other mammals, it seems to behave like a calcium channel blocker. Treatment supportive, again, no known human toxicity or exposures. So the next is red squill. And it's a cardioactive steroid, which certainly has some human toxicity, but why it's not thought to be that toxic to humans is because it's highly emetogenic. So whether it's kids or somebody trying to harm themselves, they start to vomit once they get a significant amount ingested. Why it works for rats is that despite what this strange child's jungle gym shows, rats actually cannot vomit. And other rodents, it's kind of the same thing, is that they can't vomit. And essentially, they lack the brainstem pathway for vomiting. So they lack that kind of vomit center within the brainstem. And there may also be some anatomical issues preventing them from vomiting as well. So cardioactive steroids, they all have the same basic structure. They've got the sugar moiety, the steroid nucleus, and then the unsaturated lactone ring, which is the component that's in the red box there in the middle. So this is Scilerin A, which is the cardioactive steroid that's in red squill. This one's unique in that it's a 6-member unsaturated lactone ring, and it's a plant, whereas the rest of the 6-member lactone rings are all animal-derived. So your other cardioactive steroids include things like oleander, foxglove, bufo toad, and even some fireflies actually have a small amount of cardioactive steroid, and there's many others as well. How they work is they inhibit the sodium-potassium ATPase, essentially disrupt the ability to reset electrochemical gradients and result in increased intracellular calcium. So the diagram on the right there, I believe that's taken out of the Gold Frank. So normal physiology, so sodium comes into the cell, you get depolarization. So that's kind of phase 0 of your action potential. And then phase 2 is where calcium comes into the cell, you get calcium-induced calcium release. So then and then you get contraction there. So after that's all done, then all those gradients have to reset themselves. So you have to get the calcium and the sodium back out of the cell, and sodium-potassium ATPase is what helps reset those gradients. So toxicity, I'm sure we're all familiar with this because it's similar to digoxin as far as the cardiac steroids go. So you get the cardiac, so irritability and dysrhythmias, you get bradycardic hypotension, you get some GI upset, mental status changes, and then hyperkalemia is kind of the big concern. And then your treatment is going to be your DIG-specific antibodies. Salmonella-based rodenticides, there's nothing too fancy about this. Essentially, they're infecting the rodents with salmonella. So they don't use these in the United States. They're available in other countries, other areas, and they will often coat grains of rice with warfarin along with the salmonella enteritica serotypes. And these are the same salmonellas that have been responsible for foodborne illness in the United States from egg and poultry and other outbreaks over the years as well. So the big things you see are diarrhea, fever, cramps. Starts about 12 to 72 hours after infection, can last upwards of 4 to 7 days. And the WHO is recommending against use of rodenticide. Like I said, they don't use it in the United States anymore. Treatment is predominantly supportive, just kind of supportive to the diarrheal phase. Usually doesn't require antibiotics unless they're critically ill or the patient's immune compromised. All right, next up is SMFA, or sodium monofluoroacetate. So this chemical was registered as 1080, which just became its trade name. I guess they got a little lazy when they were thinking of the name. And then compound 1081 is fluoroacetamide, and as you can see there, it's been banned in the U.S. for a while, except in this collar form, which is shown in the picture on the right. So they put this collar around the livestock because that's where the coyotes kind of attack the sheep and things like that. So otherwise not available in the United States, but it's available in other forms in other countries like Australia and New Zealand still use it. So pathophysiology. So essentially both those compounds, they substitute for acetyl-CoA in the TCA and Krebs cycle, as you can see there on the right. So the chemical structure on the left, again, they look pretty similar to acetyl-CoA, so that's how they can substitute. And once they substitute into the TCA cycle, they are what's referred to as a suicide inhibitor of a aconitase, and that's just a specific type of irreversible inhibition of the enzyme. It essentially causes a biochemical dead end, but it also depletes any substrate and downstream products. So what happens, like a lot of other things we talked about, it decreases ATP production, you switch to anaerobic metabolism and get lactic acidosis. And then you can also get decrease in alpha-ketoglutarate, which results in glutamate depletion, which disrupts the urea cycle, and you get hyperammonemia from that. So predominantly what we see clinically looks a lot like the other rodenticides we talked about, a lot of CNS signs, depression, agitation, confusion, seizures. There's reports of long-term cerebellar dysfunction, and then cardiac, you see some QTC prolongation, VFib, VTAC have all been reported as well, and then hypotension can happen as well. Management, so decontamination. Rat studies have shown that cholestyramine actually binds SMFA better than activated charcoal, so that's an option if you get them early. And then you want to give them some type of acetate donors, because again, the problem is they don't have any acetyl-CoA. And your options are alcohol or glycerol monoacetate. acetate or monoacetin, and essentially this just increases the acetate concentrations. They can inhibit the formation of fluorocitrate. So the sources I looked at recommend 1 to 2 shots of 96% alcohol, and then starting the infusion, which is pretty, I think that's the same dosing that's recommended for toxic alcohols when you don't have flumetazole around. Other than that, it's predominantly supportive management. All right, next up is strychnine. So this has actually been around for quite a while, since the 1500s. It's been used in the past as antidotes for things like barbiturates and opioids. I guess that might get them moving if they're a little too sleepy. It's been used for snake bites. I don't really understand that one, but it's had many other indications throughout the years as well. And how strychnine works is it inhibits glycine. And so glycine is the main inhibitory neurotransmitter within the spinal cord, similar to GABA, the other CNS inhibitory neurotransmitter. It opens a chloride channel. So by inhibiting glycine, you inhibit the inhibitor, and essentially you get increase in nerve signal transmission, which results in what's referred to as kind of spinal seizures, essentially overactivity of the muscles. You get contraction of all these muscle groups, and you get things like opisthotonus, rhesus sardonicus, and facial trismus. And you may note that picture on the top right is often used for tetanus. That's because they look very similar, because the pathophysiology is very similar. So the nerve terminal on the right, you can see the tetanus toxin works by preventing release of glycine into that synapse, whereas strychnine works at the other end, so the receptor, so essentially glycine has no effect. So that's why they look very similar. These kind of spasms and things like that are often triggered by pretty minimal stimuli, even just like soft noises, turning on the lights, things like that. So early mortality is due to hypoventilation and hypoxia. Essentially, their respiratory muscles just keep contracting, so they can't breathe. And then late mortality happens secondary to other complications such as rhabdomyolysis, acute kidney injury, pneumonitis, and anoxic brain injury. Treatment is predominantly supportive, again, trying to address all those muscle contractions. So start with benzos, like all things tox, and then if it's very severe and the benzos aren't cutting it, you might just need to paralyze them and wait for the drug to wear off. Next up is tetramine. So this is illegal Chinese rodenticide, so not made in the United States, and it's not supposed to be made in China, but they still produce it in some parts of China. And there's there's been reports of outbreaks and death as well. It's probably the most famous one is this Chinese restaurant owner that essentially added tetramine to his competitor's food. His competitor owned some type of pastry bar. So 300 people were poisoned, and there were 42 deaths. And just to show you the swiftness of the Chinese judicial system, the person who did that was executed 1 month later. And then another outbreak in China was a kindergarten class. A kid brought some snacks to share with his classmates that somehow became contaminated with tetramine. They don't know how that happened, but there were 2 deaths from that. And then there was a case in the United States of a 15-month-old that was found playing with initially an unknown white powder. The package is shown there on the right. And this 15-month-old had refractory status epilepticus and permanent neurodeficits because of that. And why the kid had refractory status is because tetramine is a GABA antagonist, so similar to picrotoxin. So essentially there's no effect from GABA. So it's a pretty toxic, and it's thought to be the most lethal pesticide with very little causing fatalities. And what it causes is what you'd imagine is refractory seizures. And treatment, I have question mark. Now, certainly we're going to try things like benzodiazepine barbiturates, but you're essentially fighting that GABA inhibition from the tetramine. So you might be an option to try other anti-epileptic medications that don't use GABA, things like caproic acid and things like that. Certainly hasn't been studied or anything like that, but it's reasonable to try another agent. Other treatment options that have at least been tried: activated charcoal, hemodialysis, hemorperfusion. They've been tried, but kind of limited success. So not a lot of great treatment options for this. So next is thallium. So thallium is a similar ionic radius to potassium, so essentially goes in all areas where potassium is and impairs those systems that normally rely on potassium. The three main enzymes we think of are pyruvate kinase, which is involved in glycolysis, succinate dehydrogenase, which is your Krebs cycle, and then sodium potassium ATPase, which is involved in the transport of ions. So classically, the symptoms or signs and symptoms we see are alopecia and then the painful ascending peripheral neuropathy. Other things you see are GI symptoms, so belly pain, vomiting, chest pain, QT prolongation, and then some CNS signs as well. Seizures, hallucinations, psychosis, things like that. Measles certainly aren't an acute sign that we're going to see, but kind of weeks to months down the road. And then treatment options for this, so activated charcoal. So thallium does bind to activated charcoal, and it does undergo enterohepatic recirculation, so multi-dose activated charcoal might be an option, but then kind of the antidote is Prussian blue. And you can see that picture down the bottom right. It kind of is this lattice network of ions with the potassium in the middle. So when taken orally, it's a ion exchanger, so essentially that potassium exchanges for thallium, and then the thallium just passes through the GI tract and gets excreted in the stool. It's also an antidote for cesium. Next up is Vacor, or PNU. And actually commercial distribution was suspended in 1979 for this. So all case reports are from the early 80s and prior, so probably something we're pretty unlikely to see. But this interferes with your nicotinamide metabolism, and that results in a couple different things. One is it destroys your pancreatic beta cell, so the patient can't produce any insulin, so they essentially become functional diabetics. And it causes neurotoxicity and maybe some orthostatic hypotension as well. So management, one, just give them nicotinamide, and then treat the complications of their hyperglycemia. Sorry. All right, next is vitamin K antagonist, something we're all probably pretty familiar with, especially right now. I guess we're recording this in May of 2018, and currently there's kind of an outbreak of Rodenticides that's contaminating some synthetic cannabinoids, so we're all probably familiar with this right now. But the initial vitamin K antagonist was warfarin, and all of them have the same mechanism. Essentially, they inhibit the cycling of vitamin K by inhibiting two different enzymes, so vitamin K epoxide reductase and quinone reductase. So you essentially can't get the active form of vitamin K, which is the vitamin K hydroquinone. So with that, you can't produce your vitamin K dependent your coagulant factors, which is 2, 7, 9, 10, and protein C and S. And so, like I said, initially kind of warfarin was the first one, but rats quickly developed resistance to that, so now we have long-acting agents. So you've got a couple different categories. So your 4-hydroxycoumarins, so that's brodifacoum, dicumarol, and then your indandiones, which are diphacinone, chlorphacinone, are probably some of the more common ones. So they all have the same onset as warfarin, and it takes about 24 to 72 hours. That's because there's no effect on the circulating coagulation factors. You're just essentially stopping new coagulation factors from being synthesized. But the difference is the duration of action. So you can see the half-life for brodifacoum is much, much longer, up to 120 days in dogs. So the problem is that they just have it stick around. They require pretty high doses of vitamin K. So treatment options. First, as far as like kid exposures to rat poison, usually not consequential. Rat poisons have a bittering agent in them, so if a kid is just kind of exploring, takes a bite of it because it's small, might be some candy, they usually don't like the taste, so they kind of spit it back out. So there hasn't been any reports of a kid getting toxic from getting into rat poison. at least these types, vitamin K antagonists or rat poisons, I should say. As far as other treatment guidelines, so I'm sure all pretty familiar with the CHEST guidelines for management of bleeding while on warfarin. These guidelines are developed for people who are on warfarin, however, and patients that you might not necessarily want to overcorrect their INR. So for overdoses, people getting a vitamin K antagonist, rat poison, usually there's no concern with over-reversing them, so just give them a big slug of vitamin K. And certainly if they're bleeding, then you start to think about giving FFP or PCCs as well. So there are a lot of case reports of people requiring pretty high doses of vitamin K, and often, again, for a very long time, up to several months. And the superwarfarins, or the long-acting vitamin K antagonists, are not amenable to hemodialysis because they have high protein binding and large volume distribution. All right, and last but not least, we've got zinc phosphide. So this is often used as a fumigant, but it also might be kind of a bait. So you can see the kind of chemical reaction there. So zinc phosphate on contact with water or in the acidic contents of the stomach releases phosphine gas. And then that phosphine gas has a couple effects. It inhibits your cytochrome C oxidase, so you get decreased ATP production. You get some acute lung injury, dysrhythmias, altered mental status, seizures. They classically have this rotten fish breath odor, black vomitus. There's also caustic effect to the GI system, and you can also get liver and renal toxicity as well. So as far as management, often if patients take this trying to hurt themselves, they're frequently fatal. As you can see, it doesn't take much. Just over 500 milligrams can be fatal. And this is one that can be dangerous for healthcare workers as well, because the gas coming kind of out of their stomach can be toxic to healthcare workers as well. So that picture on the right kind of shows a method to essentially decontaminate the stomach of the gas, essentially send the gas somewhere else so they're not exhaling it or kind of burping it back up at us. So that can be toxic as well as their vomit, because that's going to be off-gassing some phosphine as well. So treatment, there's not any great studies as far as treatment options and what to do. So some case series we looked at diluting with bicarb or giving NAC, just against kind of a generalized reducing agent. One source recommended trimetazidine. So trimetazidine is an anti-anginal med, unfortunately not available in the United States, but essentially the thought is that it helps with the oxidative stress because it shifts the energy state from oxidative metabolism to glucose utilization. So there might be a better way for the body to actually get ATP. But treatment, like most things we talk about, is predominantly supportive. All right, so that's it. On the last slide here just has some take-home points. So kind of buzzwords and things to remember for each of these. So thanks for listening in. Hope you enjoyed it.